My name is Dena Weitzman, and I'm the Senior Director of Medical Affairs at Digital Diagnostics. Today, we will be diving into a case study focused on the real-world impact of AI-driven testing at OSF Healthcare. This will be presented by our esteemed guests, Dr. Mark Meeker and Heidi Schlueter. Before we begin, let's go over a few housekeeping items. First, this webinar is being recorded. Second, if you would like to ask a question, please submit it at any time using the chat feature. Questions will be answered at the end of the presentation. If your question pertains to pricing and availability, these will be answered on an individual basis. And last, if you would like to connect or schedule a personal demo, type meeting into the group chat and a member of our team will be in touch after the meeting. As part of our disclosures, I want to note that OSF Healthcare is both a customer and an investor in digital diagnostics. This investment reflects OSF's broader commitment to innovation and advancing access to care. Importantly, Dr. Meeker and Heidi are here today strictly in their roles as clinical and operational leaders at OSF. They do not have any financial interest in digital diagnostics. We include this disclosure to ensure transparency while highlighting OSF's leadership in adopting and supporting technologies like LumineticsCore. So on to the content. First, today, you get to hear from me. Well, I'll spend a little bit of time discussing LumineticsCore, as well as the importance of building and deploying a patient-centered AI. Next, Dr. Meeker will highlight why OSF adopted AI for diabetes-related eye exams. And then Heidi is going to provide us a ground level in action vantage point, sharing OSF's experience implementing LumineticsCore. So probably no surprise to many, if not all of you on this call, but we have a diabetic retinopathy problem as people are going blind unnecessarily. With millions of Americans living with diabetes, unfortunately, screening rates still remain critically low. Some health systems reporting only up to 85% not getting an annual eye exam for diabetes. This is even with all of the American Academy of Ophthalmology, American Optometric Association, and other recommendations for annual eye exams. One of the reasons impacting this is the fact that there just aren't enough ophthalmologists to meet the demand. With an even fewer percentage of those being retinal specialists, it's really critical now that we're able to screen and get those patients that need the treatment to the doctors that need them, allowing each eye care specialist to practice at the top of their license. You might have noticed that my background on the intro slide is that I'm an optometrist. In my clinical care, I worked in multi-specialty interdisciplinary settings. And I joined digital diagnostics about 5 or 6 years ago because I realized that what we are doing isn't working. It's just not meant to meet the need of everybody, even with the patient and the provider educations that could be provided about the importance of an eye exam for diabetes to prevent vision loss. And this has created a major preventable cause of blindness. Even just from the poll, I see a number of you also have lots of issues at play and numerous barriers that you experience too. For this reason, we have brought our solution to market, our AI-powered detection right into primary care at the point of care. This shifts the exam from being a referral-based model, meaning you're only referring that patient outside eye care, into something that patients can complete in the same visit. It's about screening, immediate, accessible, and routine. Digital Diagnostics founder, Michael Abramoff, created LumineticsCore because he recognized that there was a gap here that he wasn't able to reach patients. LumineticsCore consists of a retinal camera, the Topcon NW400, coupled with an AI algorithm. Operators, and these operators don't need to have prior ophthalmic training. They might be medical assistants, they could be front desk staff, sometimes it's lab technicians. These operators capture 4 images, 2 of each eye. These images are then submitted securely to the AI cloud algorithm, where a result is provided almost instantaneously, whether there's presence or absence of diabetic retinopathy. For clinicians, this means, and patients, minutes to diagnosis, seamless workflow integration, and a clear opportunity to have a patient conversation, as it's really impactful to tell that patient right there, hey, it looks like you're sitting in my chair and there's a chance that you're going blind. On top of that, it can help close HEDIS and MIPS care gaps, and also it can be reimbursable under CPT 9229. So somewhat recently, the FDA articulated the importance of addressing bias in the development and use of AI ML enabled medical devices. And for this, they created what they call the total product lifecycle for bias mitigation. I think this really answers some questions about what makes AI work in the real world. So many times, I think there's this common misconception that when it comes to mitigation of bias with AI, the onus is always only on the creators of the AI. And bias is either mitigated or even induced only in the design and development of the product. When in fact, success depends on learning across the total product or patient lifecycle from design through real world use, meaning it's not just in the AI company, but also the end user. It's thinking about things like AI conceptualization, but also the validation, AI access and marketing, and the monitoring afterwards. It's that entire total patient product lifecycle. At Digital Diagnostics, some of the ways we have attended to this is by validating in the intended setting for use, creating an incredibly friendly UI UX, making sure that it's easily operatable by all different types of operators, providing a robust implementation and integration team, and monitoring all of this to ensure we are actually closing care gaps and saving vision. My recommendation after working in this industry for anybody looking to adopt any kind of AI in healthcare is you need to work with the developer of the AI to ask that questions. Not only in the design and development phase, what steps were taken to mitigate, but how do we think about it amongst this total product and patient lifecycle? As well as you as an end user, what kind of considerations did you have to make sure that this is accessible for everybody? Which takes me to the next point. Not all AI is created equal. Our founder, Dr. Abramoff, coined a really interesting and impactful term, glamour AI versus impact AI, meaning just because the sensitivity and specificity is really great, just because it performed well and if it's clinical trials, if it doesn't actually close care gaps, if it doesn't actually reach the patients that need it, if it isn't, in our case, improving vision, or it's not impactful, what's the point? And it's this that makes a difference for patients and providers. We at Digital Diagnostics have chosen to create Impact AI, meaning it's validated, cleared, workflow integrated, and focused on outcomes. And speaking of outcomes, collecting real world evidence has actually been a big part of my job here at Digital Diagnostics over the past 6 years. And what we've seen to understand, because we know that things are very different in a clinical trial setting than they are out in the real world. So another little tidbit, recommend always ask for that real world evidence when you're considering adoption of any sort of AI healthcare diagnostic. But we're finding that in real clinics, we've seen eye exam rates jump from 25 to 71% in just 9 months. Follow-up rates with specialists triple that than they were with teleophthalmology, meaning someone that had at a clinic, maybe they got a positive result from teleophthalmology exam versus if they had a LumineticsCore exam, got the positive result, they were 3 times more likely to actually show up for that care. It's really impactful to have that output result and to show the patient that they could potentially be going blind right there at the point of care. And then we're also seeing clinics now exceeding the 90th percentile benchmark for HEDIS. But it's really more than just that. The eyes really are the windows to the body. So when we see even early diabetic retinopathy or changes in the eye due to diabetes, we have to ask ourselves what other microvasculature complications are occurring. Neurological, peripheral vascular, cardiovascular, renal, etc. And recognizing this, it's more than just thinking about the direct impact on saving vision, as well as, that kind of quote unquote typical ROI, HEDIS, MIP, CPT, et cetera, but also considering what other downstream costs and patient outcomes are improved because of the ability to detect things so early in the eye. Remember, it's more than just making AI that looks pretty. It's thinking about the entire cycle and that due diligence is on both the company creating the AI as well as those adopting, which I think OSF has exemplified. They've realized it's more than just a clinical tool, and how they adopt it directly impacts patient outcomes. So, without further ado, it's my pleasure to introduce our first guest, Dr. Mark Meeker. Dr. Meeker was the Vice President of the Community Medicine Service Line at OSF Healthcare and is a board certified internal medicine physician with over 3 decades of clinical experience. In his current role, he is the VP and CMO of 3 hospitals, where he leads strategy for community medicine while continuing to care for patients directly. He's especially committed to expanding access and improving outcomes for patients with chronic conditions such as diabetes, hypertension, and kidney disease. Dr. Meeker, the floor is yours.
Thank you, Dena. It's a pleasure to be here today. I hope we can share just a few insights to help anybody that's interested in enhancing the care of their diabetic patients. And listening to that intro, I have to say, yeah, sometimes I'm a glutton for punishment. Um, OSF Healthcare, we're a moderate-sized healthcare system based out of Central Illinois, with a hospital also in the Upper Peninsula of Michigan. We are owned and operated by the Third Order of the Sisters of St. Francis. And so we're a mission-based, Catholic healthcare-based organization, 17 hospitals, over 2.2 million patient encounters a year in our outpatient setting. So we have a pretty large population of diabetics. We take care of about 66,000 across the ministry. We are also pretty heavily into the value-based care world. Probably 25% of our business comes from value-based care, where our quality metrics have a direct impact on our finances, not just on the care of the population. So we're always we have an innovative division and a digital division, and we're always looking for opportunities to enhance the care of our patients through innovation and technology. So when we were first introduced to digital diagnostics through our innovative team, my role at that time was vice president of the community medicine service line, which included primary care. So I kind of oversaw the clinical standards for our primary care group across the ministry. I've since taken a CMO position in 3 of our facilities. A little bit of a change in venue to rekindle my fire towards the end of my career. But what really caught our attention with digital diagnostics was the application of this technology. It was just really exciting to see something we thought could really help us with our metrics and with our care, with the quality of our care, without overburdening us. So several questions that we'll get into is, that we're asking ourselves, is this something we can actually scale? Sometimes you see a good idea for a small niche, but scaling it to a large system might be an issue. So that was one of our questions, along with how much of a burden is going to produce on our staff. We went through the pandemic like everyone else did. We lost some staff. We had to tighten our belts. Hiring people became more difficult. So we didn't want to overburden our staff with all of their medical home obligations already being a certified medical home practice. So that was a very important question to us. And then, sometimes you see preliminary results and studies, but can you actually translate that to the real world? Can you have the impact in the real world on your patient population that the preliminary studies, suggest? So there were several factors that we considered when we were trying to choose a technology to help us in our diabetic screening, because we knew we were underperforming for a variety of reasons. But the main factors that we were looking at was workflow efficiency, access and scalability, which I just mentioned, cost. We do live in the real world. We have to be able to pay our bills like everyone else. Clinical accuracy is very important if you're going to improve quality, as well as patient experience. That's a real important to the sisters. We really try and be a high-performing and reliable organization when it comes to patient experience. So that was a very important consideration. And when we looked at, teleophthalmology support versus this AI-driven technology that we can actually put into our practices, you can see the comparison and contrast here. This is something that is fully automated, that you get immediate results and you can do it right in your primary care practice. That was very appealing to us because that really helps us with our efficiency and agility in getting these exams done. Spreading it, we could share cameras and put these in high volume clinics where we can, share the cost. It is an FDA approved modality with a good sensitivity and specificity for screening. And that's one thing about screening tests. We're always looking for better screening tests, and sensitivity and specificity are very important in that endeavor. So that was another high factor. And then the fact that it's so convenient, we can screen people right there in our office while they're there. They don't have to make another appointment, come on another day, go to a different building, etc. And they get that immediate feedback because it's a binary result. It's positive or it's negative, and you get it right there at the time that you do the exam. So this technology really checked all these boxes for us in a very positive manner, and really encouraged us to move forward. So we started off in May of 22, again, just coming out of that pandemic era that we all hate to even remember. And we started off with 8 cameras and some pilot sites, and you can see our uptake there was as a little slow as you'd expect as we learned the technology and just had 8 cameras and 8 practices. And then in December of 22, we decided that we needed to spread this. So we got together with Digital Diagnostics, we talked about a scaling plan, and we implemented more cameras. I think it was 24 more cameras to get us up to 32 total in January, February timeframe of 23. And we continue to have some steady growth. The thing that I like most about this graph, I think answers a lot of our preliminary questions about can we scale this and can we sustain this? And what I'm really pleased with seeing is when you go from December of 23 to September of this year, there's that continued steeper scale of growth. So not only were we able to sustain this, it's growing at a more rapid pace now than it was before. So that was really important to us because that has to do with the efficiency, the burdensome stuff on the staff, and then the sustainability. So I'm really, really pleased when I look at this graph to see that even to the very day that we're talking, our volumes continue to grow. So getting back to those three key questions that we really had in the beginning, can we scale this? We've shown that. I just showed you the graph. We went from 8 pilot site cameras to 32 total, and our growth continues to climb. So yes, we were able to scale this very effectively, and I'll be introducing someone to you here shortly that was really a big part of that process. Could we improve access without burdening our staff? Well, you saw we've done over 8,000 exams. So those are 8,000 exams that we didn't have to refer to an outside entity, to a eye care specialist clinic. Those 8,000 exams, if they were able to see other people that had higher level needs than these simple screenings. So we felt it was a win-win all the way around, which I will say real quickly, we don't employ very many eye care specialists in OSF. We have one ophthalmologist in our entire system. So we use private groups in our markets to take care of our eye patients. We talked with them before we implemented this, and we had them take a look at the technology. We talked about it with them, and they were actually very supportive and very excited about it because it really streamlines the referrals that they get. So instead of getting thousands of patients that screen negative, we're screening them, we're sending them to them, and the volume or the percentage, I'll say, of patients that we send to them that need actual intervention is obviously much higher because we've pre-screened them. So it was a win-win situation there. So our volumes continue to climb, as I mentioned, over 470 a month now, and our frontline staff is getting better and more efficient as the months go by. And then does this preliminary evidence in the studies translate to real world? We're seeing that too. We're seeing a positivity rate, which is about where we expected it to be, and getting those referrals to the eye care specialists in a much more timely fashion because they have more openings up, in their schedule. So we hope to see this really enhance our value-based care metrics and our diabetic eye screening. As was mentioned earlier on, diabetic retinal disease is a leading cause of vision loss in the United States, and we think we can have a significant impact on that in our patient population through this technology. So we're pretty excited about it still. I mentioned earlier that when it came to scaling, we were very deliberate about that, and at the time that we were towards the end of our pilot period, we realized that in order to have a successful scaling of this, we really needed a point person to oversee the spread of this technology, and a point person to be able to guide people to the right sources if they had questions, to be a problem solver, to watch the data, to give feedback, and organize. We had meetings amongst various people to make sure we were on track. So Heidi Schlueter was one of our quality improvement initiatives coordinators in OSF Medical Group, and she came on board with us with this project and really helped us be successful in our spread. So I'd like Heidi to talk to you a little bit about some of those details.
Thank you, Dr. Meeker. So with the pre-implementation, we successfully secured the clinical buy-in. Our current dashboard showcasing our current performance metrics. This initiative with all of the physicians and APPs, and we have received positive results during this implementation. The dashboard not only highlights and achieves, but also outlines for improvement, fostering collaborative atmosphere among our healthcare professionals. As part of the continuous improvement, locations with our quality priorities to fit our QI needs. Prior to implementation, the LumineticsCore was advertised and was the highlight of our grand rounds that we utilized throughout the ministry. These events were instrumental in facilitating knowledge sharing among healthcare professionals, and I believe that they were a huge contribute to the development of the program. The discussions were engaging and we received positive feedback from the mission partners that attended regarding the practical applications discussed during the sessions. It was essential that we have clear criteria up front, so they had a clear understanding of what was happening and what was expected. By embedding these into patients' annual wellness and chronic care visits, we can streamline this into our work and the workflow. In addition, while utilizing assistant-driven workflow, it helps ensure smooth handoff and among team members. This integration can significantly enhance our patient care quality. Leveraging the auto EHR documentation along with the built-in referral loop has optimized our operations. The success happened within the staff within the ministry. Our implementation timeline, as we continue to improve the implementation, key initiatives that we provided. For example, the physician champions as huge throughout the ministry, that we had someone to actually drive the program and streamline the efforts to make this successful for not only our patients, but also us as mission partners. The hands-on camera training with our super users was huge to get this up and going. It enhanced their skills, but also empowered them to assist their peers more efficiently. To streamline the onboarding process, I suggest creating an integrated tip sheet that can serve as quick reference guides for new years in reference. It's kind of one of those things that if you don't use it, you lose it, or if you don't use it enough, you don't, you're not comfortable in using it. So the more you use it, the more comfortable you get. We started with 8 cameras and then quickly, like Dr. Meeker mentioned, scaled to 32 of the cameras. In May of 2022, we had the 8 cameras, and then as you can see, we streamlined, and then just now over the years, we have screened a little over 8,000 patients. Any health system can achieve these numbers with the right implementation and support. So I'll talk a little bit about the workflow. It's important to always be prepared ahead of time. You always want to make sure you know which patients are coming that are diabetic, so you can prepare to ask them about their screening. So having a plan prior to seeing the patient before the appointment is absolutely huge. It can also be a smooth process for those being screened and were unexpected due to add-on appointments. Once screened effectively, the results are available almost immediately, not only allowing the patient to see them, but also the provider to discuss those results and the next steps that may be needed. The results are routed then to the EHR, so the patient can always access those results, taking them if needed to, they can show those results to that professional so they can see that. If the patient has a result of no diabetic retinopathy, then no action is needed. So on this next slide here, I will show you what the result actually looks like. So this is what the report shows for the patients to see. As you can tell that it's fast and it's clear and it's actionable. Down here at the bottom, it'll say referral needed or no referral needed if the patient was screened positive. The convenience drives the adherence and ultimately prevents the vision loss for the patient. Our clinic's quality rating have consistently trending positively due to the metrics, because of this AI metric that we are able to use. And then in conclusion here, just some key highlights regarding our ongoing quality improvement program. Our leadership remains committed to championing this initiative, ensuring that we align our goals with high standards of care. We have established a monthly cadence for quality improvement meetings. These sessions help us track progress, share insights, and address any challenges we may face. We are making strides in integrating our program and the EHR systems to minimize workflow disruptions in our staff, enhancing our efficiency in our operations. Effective training is being provided to empower frontline staff. This will enable them to implement quality improvement practices more confidently during their interactions with patients. And of course, our goal is to have a quick and efficient process that can seamlessly be driven. And then now we'll show you a video.
Diabetic retinopathy is a complication of diabetes that affects the back of the eye and can cause vision loss, blurry vision, and other complications.
I initially was dismissive about the eye test because, again, no symptoms. It's really hard to think of something being wrong that's not actually causing things that you're noticing are wrong.
So for all our controlled and uncontrolled diabetes patients, this is part of a preventative. So when they come in, we have our machine here, and it consists of 4 pictures, 2 of the right eye, 2 of the left. They get the results right after the exam, and if they have diabetic retinopathy, then we will refer them to a specialist where they will start treatment.
And now that I do know, I can take steps to prevent the worst possible result, which is, again, going blind. I don't want to go blind.
Some patients didn't even know about it, and it really helps those patients. Some patients, they're like, well, I'm having some vision loss, or my prescriptions just aren't really right. Well, a lot of that has to do with the diabetic retinopathy. So those people that are having those vision issues, they didn't know that it was because of their diabetes that is affecting their eyes.
This has been really great. I want to say, Dr. Meeker, Heidi, thank you for so much for taking us into kind of OSF Healthcare's mind and even the clinical setting. Such a great video there. While we're getting some things in from the Q&A from the chat, I actually have some questions for you all. I was hoping you could kind of tap into a little bit more. Heidi, I love so much that you all considered, I know I'm taking this back to that total patient product life cycle, but you all considered at heart, like pre-implementation, like we want to work to include this into provider education. I think, CME, and also in particular, reaching out to ophthalmology ahead of time to make sure that they're comfortable, because that's the entire cycle. If they're not happy and they're not wanting or feeling like this fits into it and actually treating those patients. My question to you, Heidi, is how did you engage frontline staff and secure their buy-in during the rollout? And additionally, what kind of role did training and super users play?
So being upfront and honest with them about the workflow and building their trust, that's huge. And showing them that it can be done, and patients really like that with the information that's coming from you. The super users, they would go on site and help with the training, as well as digital diagnostics was also a great resource as far as training. But building that trust and getting patients and the other mission partners to understand what we're actually doing for the patient and the result of saving the patient's vision is really huge too.
Heidi's conclusion kind of triggered a couple of thoughts that I had, for people to be successful here. One is she talked about clinical and operational champions. And that really is important. We had a couple of physicians that when they went through this education and the review of the CME on retinopathy, they really grabbed onto this. And where you have a physician champion that really grabs onto it, the volumes increase much more rapidly than if you have somebody that's kind of begrudgingly cooperating. So having, several physician champions throughout the practice was critically important to us. And the other thought that she provoked was when she showed that sample of what the patient can see.
Mhm.
Over the course of my career, I've learned many times that a picture is worth 1,000 words. And when you can show a patient that there's something going on, they are much, much more likely to follow through with their eye specialist appointment and getting that evaluated and then getting serious about their diabetes control because they can see that there is a consequence. They don't just hear words from our mouths. They can actually see the consequence on the screen. So that's also a huge factor.
Yeah, no, it's a great call out. People fear very much going blind, rightfully so. And I think so often because diabetic retinopathy, patients can be asymptomatic until the later stages, when sometimes it's almost too late to receive the treatment. So you want to catch it early enough that the treatment can help preserve and save the vision. And then once the symptoms come on, you've almost reached that point, which is why screening is so important. So I think sometimes it's sort of one of those with so many appointments, not only do these patients with diabetes have a number of appointments, but often so many comorbidities, right? It makes sense exactly what you're saying, Dr. Meeker, to have it right there. It's that wake up call. It's no longer a question of when or if, it's potentially now. So it's a great call out. Heidi, I was hoping that you could talk a little bit more. I loved how you called out that you all try to integrate this into annual wellness visits and chronic care workflows. Can you give a little more details about how you kind of did that, maybe with respect to your Epic or Epic integration or workflows? How did you integrate these?
So recommendation is for diabetics to get an eye screening yearly. Not only that, hemoglobin A1C, but diabetic foot exams yearly. So we kind of implement that all in one. So when they come in and say, hey, you're here for your preventative exam, let's look at what else can we do for you? What else can we take care of while you're here to stop or to so they're not going to so many office visits within a few months time. So, kind of like you're here now, so let's get it all done so you don't have to make another trip type of thing.
No, absolutely. I love that. And the proof's in the pudding, right? Look at those adherence rates and the improvements there. They really do speak for themselves. Kind of related to this, Dr. Meeker, I was curious, how you felt in particular OSF was able to, advance their mission of improving care, but in particular for rural and underserved communities. Can you speak a little bit to how LumineticsCore kind of facilitator helped kind of with that and reaching those communities?
Yeah, that was kind of interesting, actually. When we looked at our preliminary data shortly after spreading it to the total of 32 cameras, we noticed that there was a quicker and more intense pickup in our rural clinics where we placed it. And when you think about screening for retinopathy, the people who are at highest risk are in many cases people who are not as well controlled and have less access to care because of all the social drivers of health that they're dealing with. And some of that is transportation and remote locations. And so we did find out when we put these cameras out in those communities that the uptake was even more so than in our more metropolitan areas because that lack of access to transportation to eye care specialists. So it really did help our rural markets. We noticed the same thing with, like we initiated a liquid biopsy for lung cancer screening, for example, and we noticed the same things there. Our rural patients that are further away from the low dose CT scanners for lung screening really took up to the liquid biopsy. So it's the same concept. It's really taking the technology to the patient instead of the patient having to come to the technology.
Yeah, absolutely. I love that. I think so many times there's such a discrepancy between different types of clinical environments and whatnot. And what I love about like an autonomous AI is you can uniformly, sort of provide this across the board. So really, really insightful. It looks like we do have a question here in the chat. Uh, Probably for you, Heidi. Can you talk about the workflow for placing an eye care specialist referral when a patient has a positive screening?
Sure, absolutely. So obviously the provider will go ahead and talk to the patient about the results of the exam, tell them it was positive. So they're going to recommend that they see an eye care specialist. For our organization, we'll put the referral in. It'll go to a work queue, and then from that work queue, someone will work that work queue. They will call the patient. They will ask the patient where they prefer to go, and then they'll send that referral over and then make the appointment. And then everything is seamless, and the patient can get in, see the eye care professional. The result does go into the patient my chart for the EHR, so they can also take that result with them and show the eye care professional what that looked like on there, and so they can whether it be they don't have retinopathy or they do, for further testing.
So I think too, kind of along those lines, I did notice in the chat that there was almost a majority of the people that answered the poll said that integrating the screenings into existing workflows is a concern. And we had that same concern. That's why we're looking for something that wouldn't overburden our staff, as I mentioned early on. But it really is, there's several different entry points that we can use. We can do proactive outreach and mine the EHR to find diabetic patients who have not had their eye exam done, and then proactively outreach to them and say, hey, can you come in? We got a screening we can do right here in the office for your eye exam. When the patient registers to be seen, or when they make an appointment to be seen, they can be asked at that time, have you had your eye exam? And if the answer is no, that can be added to their appointment request. When they show up and are being roomed for the appointment, the roomer can say, oh, I see you haven't had your eye exam. We have a machine right here. Can we get your eye screened while you're here? And once in a while, as their physician, I'll walk into the room after they've been roomed and they haven't been caught in any of those points yet. And I'll notice that they're due for exam and I'll ask them, hey, I see you're due for your eye exam, or overdue most often. We have a machine right here we can screen you with right here in the office if you're willing to take, an extra 5 minutes a day to do it. And so there's multiple entry points there where we can, plug the patient into the screening. And then it's just a matter of, we have medical assistants in the office that have been trained on using the machine, just taking them down the hall, just putting them in the machine like the picture shows here, taking that quick photo. Our diagnosability is just under 90%. So 9 times out of 10, we get an adequate image to screen. And then the patient's taken care of. So there's multiple access points there without a huge disruption to our workflows.
Yeah, I love that. Again, I think that's really part of the solution, and thinking back to that whole life cycle and ways of mitigating bias. Like, one solution is not going to work for everybody. It's not going to work for every clinic. It's not going to work for every patient in terms of identification and when to offer it. And so I love that you have different sort of points where you can identify and say, hey, to not let this patient slip through the cracks. So I think that was really clever.
And then the one other point that I'll make along those lines is we have a number of small primary care practices that might be one clinician, maybe even just an APP as a solo practitioner there, and they simply don't have the volume to put a camera in every single practice. We have 120 practices or whatever, but we have 32 cameras. Now, some of those cameras are in bigger buildings where we have multiple practices. But if we have a small practice that can't sustain a camera on their own, we've also developed an internal referral process where they can refer that patient to the closest primary care practice that has a camera if we can't get them into an eye care specialist. The standard of care is still to get them into an optometrist or ophthalmologist, but if that's just not practical, either for access reasons or social drivers, house, whatever, then we can still offer them this screening, even if it's in a neighborhood, sister practice and not in that particular building. So we've also developed those referral processes.
Yeah, as an optometrist, I approve that sentiment, like 100%. In an ideal world, everybody's going. But to your point early in the call, Dr. Meeker, you mentioned we don't have a lot of ophthalmologists within your health system, right? Let alone even outside the health system to attend to these patients. And on top of that, the data shows, like it's shown, 85% not closing that care gap for so many reasons. Like, again, some of them listed that you all listed in the chat, but there's so many, you got to think outside the box to really reach those patients. So it's a great call out. Dr. Meeker, a question for you. How did you evaluate whether the clinical evidence behind LumineticsCore would translate into real world outcomes for your patient population? And what was kind of that aha moment when you knew LumineticsCore was the right fit?
I think it was sort of if you remember that graph of the number of screenings we're doing, I honestly can't really say that there was a single aha moment. The technology, when we evaluated it, was very intriguing. The data that was presented with the preliminary trials looked very strong. And then when we started to see our own patients screen positive and get referred on for a higher level of care, we just knew we were doing the right thing. But the one thing that we pointed out to people, maybe this was kind of an aha moment, was before we started doing Luminetics, think about how many of our diabetics were walking around out there with early retinopathy that's going to eventually lead to visual loss that we didn't know about. So you have a diabetic that you're taking care of. You've been asking them to get their eyes screened. They just never have done it because it's been an inconvenient thing to go do. And they're walking around with early retinopathy that's starting to take their vision, but not to the degree that they're noticing it yet. And if we can find them at that degree and then get our eye care specialists to intervene, because that's the other thing that we haven't really talked about is the improvement in interventions. So the eye saving, vision saving care advances that have occurred in the last 20 years are also pretty impressive. So if you can find that eye disease early and get them to your eye care specialty colleagues, you can save their vision. And that's a real motivator for primary care clinicians who went into medicine to take care of people. They didn't go into medicine to do a procedure or to make money, this, that. Most primary care clinicians have gone into medicine to take care of people. So when you think about it that way, that was another aha moment was, wow, we have these positive screens. We wouldn't have known they had any changes if we didn't have this technology because they didn't go see an eye care specialist. We found it in our primary care practice. So that's kind of when we convinced some of the skeptics that this was the right path to go on.
No, I love that. I think in particular, kind of piggybacking a little bit with that, like if you have those early changes in the eye, where else is it? And we're hearing anecdotally with some of the other real world evidence that we're collecting, like improvements of A1C afterwards, right? Like providers are telling me from other health systems that I've spoken with, hey, I've been on the fence about, tightening up control, but now I have a positive result in hand from this LumineticsCore exam, and I need to consider this. Like, yeah, I don't know if you experienced the same, Dr. Meeker.
It really gets back to what I mentioned earlier about a picture being worth 1,000 words. And there's always collateral benefit too. We've also, along the same time frame, we initiated a big performance improvement project on our quality side in the medical group in OSF around nephropathy screening. So these things kind of go hand in hand. To your point, if you have an abnormal retinal scan, now you're saying, have they had their creatinine in their albumin checked? Do we have an ACR on them? And what's their blood pressure again? Is their blood pressure really where it should be? And if they had a lipid profile, and where's their A1C? I mean, you start to ask all these questions once you have some evidence that things are starting to go awry. So there is collateral benefit to this exam too, more than just the diabetic retinopathy.
Yeah, absolutely. And it's, I think especially because some of this is so new and the autonomous AI is so new, right? And I can see even from the real world evidence standpoint, every time somebody thinks of just like a general ROI, it always seems like this closed off concept of like, well, CPT, HEDIS, and all of this. And also, did we protect the vision and in terms of patient outcomes? But the potential is more for that downstream impact. And that's really where I, see joining this company, I see the potential. Finding it early in the eye, to your point, what else do we need to consider? What other tests do we need to do now? What is this indicative of in other parts of the body that we can prevent? Can we prevent more emergency room visits, et cetera? And so I think there's a lot more to come.
And I agree. And we're looking at this from a very I mean, like every other health system, we're trying to make our ends meet. So we look at it from a very practical standpoint. Can we cover the cost of this? And so the collateral benefits I just mentioned, we didn't even factor into that. But there's a lot of other, collateral benefits to getting people screened.
Yeah, absolutely. Let alone the patient outcomes, right? Well, I want to, first, Dr. Meeker, Heidi, I just want to thank you so much for sharing OSF's journey so openly. And then I want to thank everyone who joined us today. Before I close things out, curious, Dr. Meeker or Heidi, do you have any last thoughts or last little tidbits for the audience?
Now, I would just stress again that when I look at that graph of the number of screenings we're doing, the thing that pleases me most is to see the growth continue this late in the game, which tells me that we indeed made a good decision. Because sometimes things are a flash in the pan. People get all excited about something and they use the heck out of it, then it just drops like a rock. We're not seeing that in that graph. You saw we continue to grow, and I give Heidi a lot of credit there because she's been a great resource for people to be able to go to for problem solving, etc. But that graph tells me a lot.
Well done, and kudos to your entire team. This has been just such a great story, and I want to thank you both again for sharing your journey so openly. What we've heard is that autonomous AI isn't a distant concept. It's already transforming care delivery at the front line. OSF's experience shows that with the right planning, the right partner, and the right workflow, it's possible to close care gaps, improve quality scores, and make a real difference for patients. If today's conversation sparked ideas for your own practice or health system, we encourage you to reach out. We'd love to explore how LumineticsCore can support your goals and help bring the same impact to your patients. On behalf of Digital Diagnostics, thank you for joining and have a good afternoon.